Okay, we're going to talk about assessment of oxygenation. And one of the things that you probably already know, assessment of the respiratory system involves inspection, palpation, percussion, auscultation. For inspection, you want to look at the symmetry of the chest. Are there any deformities that cause an asymmetry? Is the anterior, posterior, or AP to lateral, the 1 to 2, so that front to back is half of side to side, or is the patient barrel-chested, pigeon-chested? Do they have scoliosis? All of those things that might impact the visual symmetry of the thoracic cavity. You also want to look for things like retractions of the intercostal spaces. This typically occurs during inspiration because the patient is working to breathe. So normally you don't see any indentation of the spaces between the ribs, but if a patient is really thin, you might see some even though they're not breathing hard. But typically it's a sign of respiratory distress and that the patient is really working a lot to pull air in. So they're using all of their accessory muscles. Often we will see retractions of the intercostal spaces during a severe asthma attack, exacerbation of COPD, or with an upper airway obstruction because the patient is really trying hard. We can also see suprasternal and substernal retractions, supra meaning above and sub meaning below. So when we're looking without touching, those are some of the things that we will look for. Besides structural changes, we also want to look and see if there is a delay in one side or the other during breathing. This typically tells us that there may be scarring or inflammation of the pleura so that there's less lung expansion during inspiration, or perhaps the patient has multiple fractured ribs so that there's a detachment, you might say, of the structure so that we don't have even inspiration as well. We also look at skin color as part of our inspection of the respiratory or oxygenation. Cyanosis of the lips and nail beds indicates a significant decrease in oxygenation, so that we're seeing central cyanosis. Cyanosis of the chest typically is a sign of impending demise. But if the lips, the tongue, the nail beds are cyanotic, then it usually means that we have a significant decrease in oxygenation. Palpation, means that you're going to touch the chest wall or the chest. So you're palpating the chest, looking for areas of tenderness or abnormalities in the overlying tissue. This might be a crackling sensation, kind of like bubble wrap almost, that may or may not produce a sound, but usually produces a sound like crackling, like Rice Krispies or cellophane under the skin, and that tells us that air has leaked from the chest wall, and that tells us that we have a significant decrease in oxygenation. We also look at skin color as part of our inspection of the respiratory or oxygenation. Cyanosis of the lips and nail beds indicates a significant decrease in oxygenation. the chest wall for some reason and is trapped under the skin. This will usually give you some palpable bulge as well as that crinkly sound and sensation. If they have tender areas, you want to identify the location. Is it accompanied? Does it occur during breathing, inhalation, expiration, or movement of some other body part? The first photo in the upper middle is demonstrating palpation or assessment of respiratory expansion. And what you do is place your hands, like in the photo, on either side of the spine, just at the base of the rib cage. And you're going to ask the patient to take a deep breath. What you should see is that your thumbs move apart as the patient takes a deep breath and then move in as the patient exhales. If one side moves and the other doesn't, or there's a delay in movement on one side or the other, then the patient has a problem with respiratory excursion. Usually your thumbs will move apart 3 to 5 centimeters or a couple of inches. You might see reduced excursion because of pain, postural deformities, or simply fatigue because of the work of breathing. The elderly, we often see a decreased excursion because of calcifications of the cartilage in the respiratory, in the rib cage, and atrophy of the respiratory muscles, so they just don't get as good expansion. And that's good to know because it sets the aging patient up for more problems with the respiratory system. Fremitus is something that we're going to palpate for, and the top two pictures on the right demonstrate locations that we're palpating for Fremitus. And Fremitus is vibrations that can either be felt or heard when we ask the patient to say 99 or 111. Vibrations are strongest typically at the top, so in the 1 position. Accumulation of mucus, collapsed lung, lesions that block the vibrations, such as a tumor, will decrease the vibration. So any decrease in the vibration tells us there's something happening within the lung tissue itself. Percussion, we know by doing percussion that we cause vibrations that helps us hear things below. So we would anticipate that when we percuss the chest wall, that it should sound rather hollow because it's air-filled. But fluid or a solid mass would change the sound during percussion. And you see the lower left demonstrates percussion. We know that we place one finger, and then we're on the chest wall, and then we're going to tap it briskly and rapidly 2 times with the other hand. It's important that there's only one finger placed so that we don't actually block the vibrations. The vibrations only penetrate about 5 to 7 centimeters, so about 2 to 2.5 inches down. So it's not going to tell us if there's deep tumors or fluid, but it does give us an idea of the periphery. I don't know if Abby told you, but she said Dad's mom might take him.
Pretty good. That's what I have a problem with that now that he's working. He's actually. It's just I don't like going to Wichita.
Yeah, nobody does.
I wouldn't mind driving a couple hundred miles once I just go to Wichita or Tulsa or somewhere. Bartlesville's not too bad.
It's just flat open country.
No, I can handle Bartlesville. I just don't want Wichita or Tulsa. Tulsa's a nightmare.
I know, I haven't been to Tulsa in forever, which is fine with me.
I don't like Oklahoma City either.
Almost scary to even drive through those places, you know, you get ricochet or something. Kill you dead.
I get lost at the first exit. I don't know, these text messages are beginning to become like email. You reply. Mike Chris sent me a text that he wasn't going to do the Wounded Warrior this year.
Oh.
And then the text just now was from Ed to Mike Pierce. Not to me, but it was to Mike Pierce. It still comes to my phone.
Because he replied to all or something.
Yeah. So you have no deer hunting this year, doesn't look like. Except for me. You can only shoot 5 deer this year instead of 7.
Really? I didn't even know that you could ever shoot up to 7. Do they think that the population of deer are dwindling? I mean, I saw 3 just this morning.
Well, you can actually.
Just right outside of Oak Falls before you even get to the bridge.
Well, if you shoot rifle, bow, muzzleloader, you shoot like 15.
I guess that's true. You can.
But you can only shoot 5 with a rifle. Last year you could shoot 7. I don't know. Not sure what changed. Yeah, the deer populations still live there. Turkeys are way, way, way up there.
Yeah. When they're in your backyard, you know they're.
But most of them are this year's turkeys too, though. And little turkeys, not big turkeys. The coyote population is just plumb out of control. Which I intend to control a little bit this summer.
They're not a protected species, are they? But you still have to have trapping or something licensed.
You have to have a hunting license and a fur bearer's license. But
even if they're just fertilizer.
yeah, I'm just gonna leave my heads. I think you don't have to have a hunting license if you're doing like I'm doing on Eds. So you may have to have a fur bearer, I'm not sure.
That's ridiculous.
Yeah, I don't have to have a hunting license to hunt deer on Eds, but I have to have a tag to shoot a deer. You're gonna get the money one way or the other.
Yeah.
about 10 degrees cooler tomorrow than it was today. Gonna dip down to the 40s.
Tonight? Tomorrow night?
Weekend. Yesterday said we had 80% chance of rain for Saturday. I just looked at a few minutes ago and now we have 20% chance.
It almost acts like it could rain out there tonight.
You know what? We need it, man. Like, ponds are down about 2 feet.
Percussion can be described as flat, dull, resonant, which means there's an echo, hyper-resonant, meaning it sounds like it echoes a long ways, and tympanic, which would be more drum-like. Percussion and the interpretation of percussive sounds are more of an advanced technique. However, the best way to develop any skill is to simply do it. A cough is a symptom that indicates something is occurring within the lungs or the structures of the lungs that is irritating to the patient. It may indicate something trivial, such as a little bit of nasal drainage or irritation from environmental factors, or whatever, all the way to a foreign body or a tumor that is pressing on a structure of the lung. So we always want to ask a patient, do you have a cough? Do you have to clear your throat a lot in the mornings? Is the cough new? Is it something that's been occurring for a while? How often do you cough? When does it cough? What kind of things affect it? What kind of things relieve it? Has it changed in any way? Do you have any production of sputum or phlegm? Then you want them to describe the color of the sputum, consistency, any odor, the volume of the sputum, all of those things to indicate what is likely going on, so it just helps you to gather more data. The more data that you have, the more you can determine if the cough is something that is serious and needs further investigation, or is likely going to clear up on its own. With sputum, when we're describing sputum to document it or just to describe it to another healthcare professional, it can be described as mucoid, meaning it's white, maybe grayish, but it's almost see-through, translucent. Purulent sputum is yellow or greenish, usually indicating some type of infectious or inflammatory process. Mucopurulent sputum has components of both. Hemoptysis, the coughing up of blood, which may vary anywhere from being blood-streaked to pure blood. So those are all things that we need to know. Make sure that before you label sputum as hemoptysis, that you make sure that where the bleeding is coming from, that they haven't had a tooth pulled recently or a sore in their mouth or something that the blood is actually coming from the oral cavity as opposed to sputum that they have brought up from their lungs. Frequently, large volumes or odd-looking sputum will be sent for culture and sensitivity, and you want to make sure that the patient has rinsed their mouth prior to obtaining the sputum specimen, and that they're actually getting the sputum from below the larynx as opposed to just clearing the back of their throat, which is typically going to be sputum from the nasal cavity. And sometimes it can be difficult to get patients to understand the difference and to cooperate and give you the appropriate specimen. Now, I think if you went back and thought about some of the things that we discussed earlier in this assessment, you would be able to come up with signs of that indicate there's a change in work of breathing. So typically we're going to look for color changes, pallor, generalized pallor, cyanosis of the lips, the tongue, the nail beds, retractions of the intercostal spaces, unequal movement of the thoracic cavity, uneven, labored, shallow, excessively deep breathing. So all of these things we're going to look at in addition to the rate and the O2 saturation that are just kind of standard assessments. Now, altered ventilation refers to changes in respiratory patterns. This could be your tachypnea, your bradypnea, hyperpnea, hypopnea, Cheyne-Stokes, Biot's, Kussmaul's, size, and obstructive ventilation. I'm not going to sit and describe each one because they're well defined in your books, but that is something that you want to be able to visualize so that when you see it on assessment, you know whether it's a serious consideration or is a reflection of what's going on with the patient. For instance, fevers frequently cause increase in respiratory rate. It's not necessarily a reflection of poor respiratory function or even a decline in oxygenation. It represents a new need for oxygenation simply because with an increase in fever, the metabolic rate goes up, meaning the body needs more oxygen. So we're going to see that reflected in an increase in rate. So it would be a relatively expected finding to see an increase in respiratory rate with a fever. So as long as we're not seeing any other symptoms of distress, like retractions or decline in O2 sats or restlessness or whatever, then we wouldn't be so concerned as to report it immediately. Unless, of course, the respiratory rate was 40 in an adult. That may be not related to just the fever. So you kind of have to think about what is happening with the patient and what other things are you seeing, and is the rate increased or is the rate increased? So if the normal is 12 to 20, a rate of 22 with a fever, I'm not too concerned about. But if the patient only has a temperature of 100.4 and I have a respiratory rate of 40, those two things don't correlate. They don't go together, and I need to do some additional investigation and possible reporting. So you want to know, what do they mean? When do they usually occur?